Guys ready? It's going to be the best ever.
All right.
Sorry about the mix-up. We had a problem with the audio. So let me just quickly recap. Sorry about the delay here. I just wanted to quickly mention that we've got all the phone lines muted, I think including our own, or just now. Anyways, all the lines are muted during our session today. You're able to submit questions using the little question section of the GoToWebinar control panel. We are going to pause at the end for a Q&A session, so please submit your questions as you think of them. And as always, we'll be sharing a recording of this session as well as the presentation that we're going to review today with all participants. Let me quickly introduce Dr. Robert Jackson. He's a Western Wayne physician. He also has leadership positions with Accountable Healthcare Alliance, as well as just this past summer was elected president of the Michigan Association of Family Physicians. And full disclosure, serves on the advisory board of our company, Medical Advantage Group, as our medical advisor. Dyana Gebauer of Medical Advantage Group also joins us here today. She'll be helping to moderate our session. Many of you, especially joining us from Ohio, know of Dyana through her work with the rollout of the Great Lakes Practice Transformation Network grant. This is a MACRA MIPS focused program to help practices prepare. In addition, Dyana supports some of our small to mid-sized physician organization clients, and prior to that has done an enormous amount of practice transformation work herself, everything from patient-centered medical home designations, assistance with practices, to cost reductions, quality improvements, et cetera. So guys, I apologize for the delay, but with that, Dyana, I'll turn it over to you. Thank you.
Thanks, Bill. And thank you, Dr. Jackson, for joining us. Let's start by having, if you would, tell us a little bit about the size of your practice and the makeup of your office.
We are family physicians, and we have 3 different offices. The Allen Park office is the one in CPC plus Track 2, and that's where I reside. We have 5 family physicians in this office and 4 physician assistants. The family physicians are probably 3 3/4 full-time equivalents, and the physician assistants are a little less than 2.5 full-time equivalents. We have a nurse case manager in our office, and we have a pharmacist that works 2 half-days a week. We've been seeing our patients. We see patients from babies to the elderly, and we also follow them in the hospital. So we don't use a hospitalist.
Great, thank you. Tell me a little bit about what you've done today to prepare for CPC+. You mentioned embedding the pharmacist and your nurse care manager. How has that helped prepare you, and what else have you done to prepare?
Well, I've always realized that practice makes perfect. At least helps you with future challenges. So jumping in and learning how to incorporate some new thing into your practice is always a good thing. It helps you become better and better. Some of that you're going to throw away, and some you're going to keep. Well, 5 years ago, we decided to get into the Michigan Primary Care Transformation Project and got Lori Grossbeck as a nurse case manager. She's been such an addition to our practice. we would find some way to keep her. She helps patients in so many ways. More recently, we used a pharmacist a couple half-days a week, and this has been helpful, especially in very complicated medication regimes that sometimes are difficult for really anybody to deal with. Secondly, we've been in the Blue Cross Blue Shield Patient Centered Medical Home thing since 2009. We've been involved with Blue Care Network and improving cost and quality for 20-some years. So there's a number of things that kind of have prepared us for this.
Those programs have had a lot of parallel to what CPC Plus requires. So would you say that you've had a lot of policies and procedures put in place through those programs that have given you a head start in what CPC Plus will require?
Yeah. Well, for instance, one of the requirements is that we have 24/7, 365 phone coverage. Well, we've had that before PCMH, before a long time ago. Since I started practice, it just seemed to be the right thing. But creating a policy that says that is probably important. We already did that for PCMH. We had to add some things about our portal into that policy, but that policy was easily created because we had already created it. We've also been doing transition care management codes. So those things require a process. Some of that process was known but not written down. We've just taken the next step of writing that whole process down and realizing, gee whiz, there are little kinks in that process here and there, and made little changes to make sure it worked better.
How has your process been in testing processes, finding the errors in them, going through that process again? How do you make time for that or lead the charge to motivate your practice to move forward in certain areas?
That's a tough question. We have a team. So there's usually somebody we can go to in our practice. For instance, Jessica Hilton knows the ins and outs of our EHR pretty well, and Jessica can always be looked upon to figure out how to do something in the EHR. We have somebody who's been doing the quality work first for BCN PRPs, later for Blue Cross Blue Shields, quality measures, and so on. These folks have been steeped deep in all these areas, and they've become experts, if you will. So we have developed our staff to become expert in certain areas.
Great. What do you think are going to be the most challenging areas of CPC Plus, or the things you think are going to take the most effort at this
point? What seems to be the hardest is trying to wait for CMS to tell us what they mean by something before we try to act upon it. we started moving and trying to move fast, and realized that the webinars they have, the information they have, the collective if you will, there's a CPC Connect, so the collective wisdom of all the folks in CPC kind of can help you. So we've taken the tack that if we know where we're going, we're going to do is work on those things, and we're going to figure out where we have to go before we work on them. It just seems logical. Rather than fret about the things we don't know, we just wait until we know. A couple things that are hard, I think, are defining what the teams are. We don't understand that. In a solo office, it would probably be the whole office. Well, we have all these people, and we're not always here at the same time. So trying to meet weekly. Who should be meeting weekly? I think the important thing really is how well we communicate. So meetings are just a way of communicating and creating a formal device, if you will, for communicating. So I think we'll probably have everybody in the office meeting in a team-like group, and it may be more than weekly because there may be multiple teams. Trying to figure out which alternative strategies, and I'm using CMS's quote, for seeing patients outside the office, home visits, seeing them in a senior center, doing e-visits or more phone visits. We do some of those things already. We do some home visits. Dr. Angel, who happens to be my sister, has a patient who's been on a ventilator at home for close to 10 years. In the last 3 years, she's only been hospitalized once, and that was for endometrial cancer, which was diagnosed at home. So there's we can see the value in this, but it's hard to implement. Similarly, e-visits, getting the right technology so it's not an intrusion, but rather works with our practice. We already do a lot of phone care, so we don't see expanding that much more than we do. Then integrating behavioral health, just how will we do that? We want to have a lot of conversations among the practitioners in the office and, of course, the staff. Then we have to figure out if we're going to have them here, where will they be? We have to study, if you will, discuss and choose 3 chronic conditions with which to provide care management support. Those, we have a number of ideas. We just want to know what the rest of our office is excited about. This will involve our receptionists, our medical assistants, the whole staff. So what excites them, and what will they jump on and help us with? And then probably the last thing I see as difficult is risk stratification. Probably 8,000, 9,000 patients, I don't recall for sure, but it's in that ballpark, are in this office. Risk stratifying every one of those by hand, it seems daunting. So if we're looking for an electronic way of doing that so that we can adjust them by socioeconomic and other factors, but so that they're all at least risk adjusted by a machine first. So those are the hard things.
Great. We talked a little bit about what you were doing within the care delivery through your experiences with patients in our medical home and some of your care management activities. What have you seen with the CPC Plus requirements or requests on care management, and how that's changed perhaps with how you've approached care management so far, or has it?
Well, yeah. What we realized in the MyTech program is that we could probably use our nurse better than what they initially thought. They wanted her involved more in transition care management stuff, and we were already doing that. We had a process. So as soon as they kind of let her stray from that, we started. She just oversaw that process. We let the staff keep doing it, and we improved that process with her help. But then we want her to use her good brain and good skills to their highest purposes. So working with more complex cases, working with cases that require a lot of touch, working with, so for instance, trying to get a diabetic who's not in good control to be in control, who might bring 100 blood sugars in, and she can talk to them about what medications they're taking, briefly consult with us. We can make changes with minimal physician time. That's better than her doing simple work in the office that other staff members can do. And we're training our staff to do other things. For instance, we have a couple staff members, one medical assistant, one receptionist, who are trained to deliver a diabetes prevention program. This is a CDC and AMA program that once we run this for a year, we'll be able to offer it as a service that Blue Cross, Priority Health, and CMS, et cetera, will pay for. We, of course, don't know how much they'll pay for it, but this is an example of a care management support process. Other staff are helping us help our patients take better care of themselves.
And how about the quality area and choosing the 9 quality measures? How did you approach that process? Was that something you went through discussing with your team? How many did you choose? Which did you choose? Can you tell us a little bit about your focus there?
Well, this is where the dictator, Rob Jackson, comes into play. Seriously, we had a couple docs who were away on vacation. We had to make this decision quickly. And there are 14 measures. So we picked 13 out of the 14. I wanted a large subset so that if we started screwing up on one of these, that we would have some others to fall back on. If they pulled some measures, that we'd have some to fall back on. The one we left out was substance abuse, the one about substance abuse. I have always been frustrated, especially long-term alcoholics at age 65. Sometimes it's extraordinarily hard to get them to quit. I've had some success. I can think of dozens of patients that I've had success with, but generally it's so buried, it's so hard to find, and it's something that I find frustrating. So I decided to leave that one out.
Is that one your staff in your practice will try and focus on and slowly think about how you can continue to work on that, or do you think you'll just focus on the other areas of CPC Plus to start that require more focus?
Well, I think that one is one we might try to tackle once we have some behavioral medicine here. So,
how has it been in working with your EHR vendor? Have you found any successes there, any struggles, or have they really been on pace with the CPC Plus requirements outside of your request?
Allscripts was involved with CPC Plus Classic, which is a good thing for us. And so they kind of know some of the things that are going on, and they've provided some tools that seem to be helpful. They're never as fast as we would like them to be, but I think generally they are supportive. Having open phone lines, knowing who to contact at your EHR vendor is important. And those are oftentimes in different areas. Some people may need help figuring out how to create templates to do certain things. Some people may need to know how to find things so they can be measured for quality performance.
And how about your processes and your precision with billing and coding or proper data capturing in your EHR? What have you experienced around those types of things?
Well, Blue Cross Blue Shield has already created a painful process by which we bill for everything so they can find out about it. In the long run, I hope for simpler ways to do things. The BMIs are in our EHR. It'd really be nice not to have to build them each time to get them to Blue Cross. But having done that, we're much more prepared, much more ready to do the things we need to do for CPC Plus. For instance, a fall risk assessment. We know where that is in our EHR. We typically use a paper form, so we don't have to ask all the questions individually, and then we just place those answers into the EHR. Similarly, with the PHQ-9, the depression screen, we know where it is. We can put it into our note, and then we can have the patient fill it out on paper, and then we can enter it into the EHR. Those are two examples of things that can be measured, and CMS can get that information. We also want to bill for certain things, like counseling about durable power of attorney, if you will, advanced directives. There's actually some money for coding, for doing that and coding for that. But also, it's something else we can measure in the quality sphere.
And this is all important too, because I presume the more accurate your billing and coding and the more data you're capturing, it's all impacting the accuracy of the numerator and denominators that are in your quality measures. So it's all impacting the accuracy of the data you're trying to impact.
Yes. There's a number of diagnoses that are HCC, and I can't remember what HCC stands for, but those are basically high cost codes. Maybe that's what it is. So things like diabetes mellitus. Well, diabetes mellitus with chronic kidney disease, et cetera, et cetera, et cetera. Being more specific with those diagnoses increases your risk score at CMS and increases your care management payment. We are also going to do mini metal status exams on our seniors because we might be able to identify dementia. Certainly identifying it early is helpful for them and their families, but additionally,
I think we lost audio again. All right, I apologize, everyone. We seem to have lost our audio connection, but we're back. Why don't we do this? Why don't maybe you guys can take a break for a second, and before we move to the next phase. At this point, we've talked about a lot of things around CPC Plus, from the EHR IT component, care management, case management, how to facilitate team meetings within the practice to keep everyone on board, some billing and coding. Emma, if you would, maybe we can just do a quick poll and get a sense of what people are thinking about. So please go ahead. You should see it on your screen now. Select the areas that you're thinking about, that you're most concerned about, whether it's care management, financial reporting, compliance, or project management is another. We'll give it just a second as people make their submissions, and then we can talk about the results. Okay, thank you, Emma. So as you guys can see, it clearly is a race for second place. The overwhelming area is data and quality reporting, 56% of our attendees. Care management, 28% of people are thinking about that. Financial reporting, 11. EHR, vendor management, 6. Okay, very interesting. Thank you all very much. So with that, why don't we flip back to our slides, and Dr. Jackson, if you could share any free advice you would have for our practices listening in today.
Well, data. As I said, you have to know everybody you can at your EHR vendor. They know how your EHR can report quality. They know how to help you generate reports. When you generate reports, you're going to want to look at how those reports look. Are they as you expect them? Is something missing? So if you expect that something like, just an example, mammography rate is low, or that some other quality measure is low, you're going to want to look into that and see what's wrong. Sometimes you have to put things in certain places for the quality scorer, if you will, to measure it. So your EHR vendor will be able to help you figure that out. You have to have numbers in for things like hemoglobin A1Cs. So if you're getting
Mm-hmm.
faxed to your office, there are no numbers in the computer. So creating an electronic connection with your lab, there may be some expense, but it may be cheaper in the long run than having people hand enter those hemoglobin A1Cs. So there are a number of things that you may find that aren't being picked up by the EHR, and you have to talk to your vendor about how you can improve that. This may cost some money, but in the long run, you probably save a lot of staff time.
And how have you, we talked a little bit about huddles and the importance of getting the team together, but I would say additionally the importance has been is having a physician champion who's really there to embrace the change and do things, you know, like suggesting the direct connection to the EHR so it opens up staff time. How have you and the rest of your physicians in your practice really been able to embrace that change and be the champions for change in programs like this?
Well, I think it's important to have physicians involved. We've been, you know, we've had physician meetings, if you will, just to kind of talk about some of these things, to get an idea that we're going to all walk in the same direction. There's nothing worse than the staff hearing that Dr. Jackson wants to go this way, but Dr. Angel, his sister, wants to go the other way. That's how it usually works in our practice. Seriously, trying to get all the physicians, all the practitioners to have the same ideas about things. And then it's much easier for the staff to follow you. They're not seeing different, if you will, commands from the physicians. So leading in the same direction as a physician team is vitally important.
And your practice has implemented things like standing order protocols, where you're really using your staff to the height of their licensure, creating, I think, perhaps more ownership over processes and more responsibility. How did you begin that process of doing written protocols, and how has that helped advance processes for you?
Well, for instance, we've had a point of care tool that I had failed to mention. So we've had this for most of the time we've had an EHR. We've had the EHR for nearly 10 years on the 26th of this month. And the practice management tool was actually bought, one that was bought by another company. So it kind of, at the time of the visit, we get those printed. That's a fairly simple process for the medical assistants to do, and it helps them prepare for visits. It tells them which HEDIS measures are not addressed. It tells them things like the patient seems to need this immunization, seems to need a mammogram, et cetera, et cetera. That is, those things are not in our EHR. Now, it took us a while to make that tool work well because sometimes it didn't always see what was in the EHR. It's that working with your vendor kind of thing. And now our medical assistants will, at a well visit, put in an order for a mammogram. They'll put in the order for the hemoglobin A1C, glucose, lipids. They'll give immunizations. All this, and do a spirometry on COPD patients, all before I see a patient. So the queue time is a little longer. We probably need a little bit more in the way of medical assistant staff. But when I get into the room, I'm dealing with their illnesses, not with all those chronic care things. The things that I have to do in the quality realm are urging them to do something that they haven't done, and things like colonoscopy, which require a consultation with another doctor or a they're given leeway to give all, for instance, non-live vaccines without a physician that have not, if you will, met certain criteria.
As we've discussed, you've had a long foundation of other programs and other things you've embraced in terms of change to help you prepare for this. But for practices that perhaps this is all kind of new to their practice, do you think it's just as important to do some of the plan, do, check, act, and lean processes that your practice has engaged in previously, or do you think it's important really to push hard and forward with CPC Plus? Do you think there's that time to test processes?
Well, any process you put in place is the first guess at something that might work. So certainly you want to get as many people involved in creating a process as is possible, and then you're gonna have to test it, and let's see how this works for a month, for instance. And don't be afraid to tweak it at every minute you see something wrong. That's the way you get fast improvement. And then having everybody on the team being able to contribute to that process improvement is important. So if the medical assistant is having trouble with something, I don't want him or her to have trouble with something. I want them to be able to get things done easily and whatnot. So that's plan, do, check, plan, do, study, act is a good process. It's kind of baked in now here.
We've talked a lot about your weekly team huddles that you do within your practice, and in considering that quality is a concern for a lot of folks on the line who are in the program, do you bring quality measures and scores for review within those team huddles? Is that something you do at a practice level and discuss how to improve scores or why they might be low?
Yes. We have a young lady, Renee, who's worked with me since she was 14 or 15 years old. At first, she was putting X-rays into files after school. She went to college and she came back. So she's a smart individual. She has a bachelor's degree, so we want her to do things that are, in line with her capabilities. And she's our quality guru. She does other things, but that's a large part of her job. And so she goes and she looks, for instance, in our EHR, tries to create quality reports, see where we're at, looks how we can change things. She'll take Blue Care Network, Blue Cross reports, and bring them to our medical assistants and go through them with them. And we've already given her the ability to kind of direct that. So everybody can help with that. We've done less with the other staff members, the receptionists and others. So tomorrow we're going to have an office meeting. We've had a quarterly office meeting for years, sometimes more often than that, but at least quarterly, where we go over practice stuff. And that's helped us with quality improvement. So tomorrow I'm going to go over cost and utilization reports that we have, and also quality reports, so everybody in the practice has familiarity with it.
Okay, very good. So as we start to wrap up, we've had a couple of questions that have come in, so I'll maybe share these with you guys. Interestingly, they both relate to the relationship between your practice and specialists. So the first question is, can you talk a little bit about how you collaborate with specialists? Do you have a collaborative agreement for the specialists you refer patients to?
Well, my practice is in AHA, which is recognized as an organized system of care for Blue Cross Blue Shield. So there are already agreements from AHA with AHA and the specialists in some cases. But our own practice has had to deal with when it came to meaningful use. So we had to look for practices that would electronically, with whom we could send referrals electronically, and they could send, if you will, consultations back electronically. So that was the beginning of our relationship building. We have staff members who are involved in various care coordination activities who kind of know other people at the other offices. So we're really in beginning stages there. But we're going to choose the ones with which we have that electronic connection first, realizing that they're probably more ready for prime time than the others. Certainly, we're going to want to look at specialists we use a whole lot. And we're going to have to get them to realize how important it is to get reports of things they do to our office. That's a perennial problem, and they don't teach that in subspecialist school.
Very good, very good. I think that addresses our questions. Let me just start to wrap up here. First of all, by thanking Dr. Jackson, Diana, thank you very much for joining us here today. Great job, as always. I want to quickly go through the commercial portion of our program and talk a little bit about Medical Advantage Group. For those of you in the CPC Plus program, please know that we're available to help, whether it's an individual component of CPC Plus or a general compliance service where we're just helping you, making sure you're on track for your next submission and your next deadline with CMS. One of the things that we like to talk about with respect to our services is you're getting our help in person, in your practice locally, face-to-face assistance, and we price our services accordingly. We've got a lot of information available on our CPC Plus program on our website. You see the link there, so please feel free to download for more information. I know a number of you have joined us on a few of our CPC Plus webinars at this point, and I'd like to announce our next one, which is coming up with Carrie Spunar, our Director of Marketing. She's going to go deeper into the care delivery component of CPC Plus. That's coming up later this month, March the 29th at noon. And if you have any questions or would like to talk to someone at Medical Advantage Group, we'd love to hear from you. The contact for those of you in Ohio is Sherry Kent. For those of you joining us in Michigan, the person is Jeff McKay. So again, on behalf of all of us here at Medical Advantage Group, Dr. Robert Jackson, thank you all for joining us, and have a great rest of the day. Thank you very much.